Hello everyone, I'm Dr. Shruthi, Junior Resident in the Department of Radio Diagnosis and Imaging, KMC Manipal. Today we'll be discussing pediatric abdominal masses, a case series highlighting atypical presentations and diagnostic challenges in the same. Coming to the background, malignant abdominal pelvic tumors in children are rare, usually present as solid masses. Among the malignant tumors, the most common ones are neuroblastoma, Wilms tumor, hepatoblastoma. Others are lymphoma, germ cell tumors, rhabdomyosarcomas. Imaging is essential for diagnosis, staging, and follow-up of these neoplasms. So the objective is to highlight the radiological features of three distinct pediatric abdominal masses and to discuss their atypical clinical presentation, imaging modalities, and diagnostic approach. So coming to the first case, it was a 5-year-old male child who presented with history of fall from bed with low velocity trauma followed by left-sided flank pain. He then developed fever, vomiting, hematuria the following morning when he presented to the emergency triage. Ultrasound showed a heterogeneous lesion involving the upper and mid pole of left kidney and moderate ascites. Blood investigation showed a serial drop in hemoglobin. Patient was then referred to a tertiary center for further management, where a plain and contrast CD study of abdomen and pelvis was done. So coming to the axial sections of the CCT abdomen that was done, a large area of predominantly blood attenuation was noted involving the left kidney, that is the upper and mid pole region, and the left perinephric space, suggestive of a large hematoma, perinephric hematoma. A focal area of contrast blush was also noted within the hematoma, which was showing an increase in size in the delayed phases, suggestive of active extravasation. Few areas of soft tissue attenuation showing heterogeneous enhancement were also noted in the upper and mid pole of left kidney. A moderate amount of hemoperitoneum were also seen. The child was then taken up for biopsy of the lesion, which showed extensive hemorrhage and focal necrosis. After initial stabilization, he then underwent neoadjuvant chemotherapy followed by left nephrectomy, which showed an underlying residual viable Wilms tumor. So this was the CT that was done post 3 cycles of chemotherapy. The previously noted hemorrhagic lesion showed an interval decrease in size and attenuation, now showing a cystic lesion with thick walls and internal septations. So coming to discussion, Wilms tumor is the most common renal tumor in children. It's more often sporadic, presence in children below 5 years of age. Clinical presentation varies from asymptomatic abdominal masses to hypertension, abdominal pain, hematuria, or retroperitoneal hemorrhage manifesting with anemia. Most important differential diagnosis is neuroblastoma. Imaging findings typically include distorted renal parenchyma creating claw sign, as can be seen over here. Calcifications are very uncommon, and vessels are usually directly invaded or displaced by Wilms tumor, frequently involving the renal vein and inferior vena cava. So, renal hematoma in children without significant trauma should raise suspicion of underlying neoplasm. There are two major approaches for the treatment and staging of Wilms tumor, and the main difference between these two guidelines is the timing of surgery. The International Society of Pediatric Oncology recommends preoperative chemotherapy, as was done in this case, whereas the Children's Oncology Group recommends primary surgery before adjuvant therapy. The tumor response to therapy can be assessed by a reduction in the tumor volume, presence of necrotic areas, and an increase in intralesional fat and calcifications. So that brings us to the end of the first case. In the second case, a 6-year-old male child came with complaints of pain in the right knee for 1 month, associated with fever and no history of trauma. He was admitted and evaluated for the same, initially managed as a case of autoimmune hemolytic anemia with steroids. 1 month later, he was readmitted for the same complaints with new features such as outward protrusion of left eye, low backache, and abdominal pain. So an ultrasound abdomen was done which showed a homogeneous isoechoic lesion in the central retroperitoneum. A radiograph was done as well which showed an increase in radio opacity involving the abdomen and displacement of bowel loops inferiorly, as can be seen here. Radio opaque area was noted in the right lower lung zone, which was not showing any silhouetting with the cardiac shadow on the right side. A CCT, posterior mediastinal mass and abdominal mass was suspected, and a CCT abdomen and thorax was done for the same. So as we can see in the axial and coronal sections of the planar and contrast abdomen study, a large ill-defined soft tissue density lesion showing mild heterogeneous contrast enhancement noted in the retroperitoneal region, which is also extending to the posterior mediastinum. The lesion is noted to encase and involve the renal vessels, and anteriorly it is displacing the abdominal and thoracic aorta. Few specks of calcification are also seen. So on biopsy, this came out as a retroperitoneal. This retroperitoneal mass came out as a neuroblastoma, and it also showed bone marrow infiltration on the right and left sides, which can explain the pain that the patient presented with. Coming to discussion, neuroblastoma is the most common extracranial solid tumor of the childhood, and most of these cases are diagnosed below 5 years of age, similar to nephroblastoma. It can arise anywhere throughout the sympathetic nervous system. The most common sites are the adrenal region. Next, we have extraadrenal retroperitoneum, as seen in this case, paraspinal chest region as well. So, calcifications and intraspinal extension is very common. Pain is frequently due to bone marrow infiltration by the lesion. The major differential diagnosis for the same are nephroblastoma, lymphoma, and extramedullary hematopoiesis. Lymphoma can be seen in older adults and adolescents who present with B symptoms, and the lesion is frequently homogeneous soft tissue mass with lymphadenopathy that is very frequently seen, no evidence of calcification, unlike in neuroblastoma. Extramedullary hematopoiesis shows multiple soft tissue masses often seen in the bilateral paraspinal region. And again, there is no particular age group for this, which can be seen in any age with patients who have chronic anemia. Coming to the third case, a 1-year-old male child presented to the hospital with complaints of constipation, abdominal pain since 15 days. Past history of recurrent UTIs were present. On per abdominal examination, a mass was palpable in the lower abdomen. A CT abdomen with contrast was done. So, going through the axial and coronal sections of the CCT abdomen of this child, multilobulated heterogeneously enhancing mass lesion, soft tissue density lesion with few necrocystic non-enhancing areas were noted involving the bladder, based at the trigone of the bladder, and suspicious extension and involvement was of the prostatic urethra was also noted. There was associated gross bilateral retrograde hydrouretronephrosis. On biopsy, this had come out as a case of embryonal rhabdomyosarcoma. So this is again rare but an important pediatric malignancy, typically seen in this age group of 2 to 6 years with male predominance. The embryonal subtype or the Botrel variant is the most common type, and it often arises at the bladder trigone. Ultrasound shows a heterogeneous intravesical mass, which is sometimes polypoid or grape-like. And MRI CT is very useful in assessing a local invasion, lymphadenopathy, and the presence of distant mets. Usually, it shows a favorable prognosis with appropriate early treatment. So that brings us to the end of the discussion. These are my references.